Well, let's get into breathing pattern disorders, the manual therapist and exercise specialist as the most noble mechanic. And we say that is because it's a mechanical process to fix somebody's breathing. It's a physics process. You're not going to do it with chemistry, you're going to do it with physics. And this is probably one of the most important things you can do as a manual therapist and an exercise specialist to, to improve the overall health of your clients and your patients. Okay. A lot of this work that I'm showing you here is based out of Leon Scheitau's book, Recognizing and Treating Breathing Pattern Disorders. If you're hungry for more or more details, then just go read this book. Okay. Let's get into it. Okay, so breathing functions of the diaphragm. And so you've got the diaphragm here and here. And so this one is the exhalation phase, and this one here is the inhalation phase. And so as the diaphragm inhales, it actually flattens down. So there's a movement, and it's about 4 fingers width of the person. And so if they're a bigger person, it moves farther. If they're a smaller person, it moves less. So it's about 4 fingers. That's just a rule of thumb. Okay. And so as it comes down here like this, there's a pressure change. So there's a pressure change. So the pressure down here underneath the abdomen is increased, and the pressure up here is decreased. And if there's a decrease of pressure in your thoracic cavity, and that pressure on the outside, the air pressure hasn't changed, what happens is the air rushes in, and that's inhalation. And exhalation is just the diaphragm relaxes. You've got a high pressure down here in your abdominal cavity. There's like the organs are full of water, so that water was compressed, and now it's going to want to push back. Now I'm going to get into that in detail in stability. And so that pushback actually pushes the diaphragm back up in relaxation. Now, if you're trying to like blow out candles or try to create like a forced exhalation, then you're going to have muscle contractions, and some of that is going to come from the quadratus lumborum. Okay. And so that is breathing. Let's get more in depth and take this piece by piece. Don't try to watch the whole thing at once. If it's brand new to you, just watch 20 minutes and then 20 minutes and 20 minutes. I'm going to try to make this as simple as possible, but it still has to have value, and valuable information takes time to assimilate. It just is going to take some time. So don't worry about it. Take your time and get through it, and you're going to be a completely different level of healthcare practitioner after we're done. Okay, breathing affects everything above and below the diaphragm. So your diaphragm's moving, right? And so, like I said before, the diaphragm is relaxing and contracting. And so the diaphragm's sitting here. But look, what's above and below the diaphragm? And I'm talking about this in detail in the 3rd lecture, the manual therapy portion. Okay, so I'm not going to go too much. I'm just going to hit the highlights. And if you want more, watch the manual therapy portion. Okay, and so as the diaphragm comes down, what happens? Well, your liver, your stomach, your intestines, all of this stuff, everything below the diaphragm must move down. Okay, and so as the diaphragm moves down here on what happens to everything above it has to follow, because everything is tied to the next thing. There's nothing independent in your body. Everything is tied to each other. And if you can follow that logic, then you'll know how to get to things you can't even get your hands on. And so what we're doing in the manual therapy is we're releasing everything above and everything below. Now, we're looking at diaphragm function in relation to lymphatics and movement. And so your liver here, in a normal breathing person, 20,000 breaths a day, the liver will move 60 feet a day, up and down 60 feet. The stomach about 60 feet, but your intestines and your kidneys sitting here, they're going to move a mile a day, up and down, a mile a day. Your intestines, a mile a day. And so there's a lot going on with that, as you got digestion happening and that continuous squeeze. Now you're going to think about lymphatics. Your lymphatic system, what is that? Your lymphatic system is your septic waste system. And so it pulls out septic waste and it brings in nutrition. Okay, it's the interstitial fluids around your cells. So you got one cell and two cells, and the fluids in the space in between is interstitium. That is your interstitial fluids. That's your lymphatic. So as this cell dumps waste products, so now you got waste products coming in, that waste products need to be mobilized and moved out. Okay, so what is the pumping system for that? Well, it's mostly a muscle pump system. It's based on movement, and the biggest muscle pump is your diaphragm. It is your diaphragm, because that diaphragm is moving your organs, your liver 60 feet a day, and your kidneys and your intestines a mile a day. And so now get the visual here. So if I take the kidneys, or say I take the liver and I squeeze the liver, I'm squeezing out septic fluid just like a sponge. And then I open the liver up because I release it with the diaphragm. So the diaphragm lifts away from it and it opens that liver and it creates a suction into the interstitial fluids. And so that squeezing and opening and squeezing and opening, that is the lymphatic removal system of your liver. And all the organs work that way. They must be squeezed and released. They must be moved all the time. So we are human beings. We are moving in space and time. Every part of your body must be moving in space and time, or it will be dysfunctional and eventually die. Right? That's the definition of death, is you stop moving in space and time. And so the diaphragm is the key to your organ movement in space and time. Okay. I mean, the heart's in there pumping away, but it's nothing like the diaphragm. The diaphragm is moving things. And I've got those numbers on a slide, the movement numbers of the kidneys and the liver and all that. So you can screenshot that. Here it is. So if you want to screenshot this, go ahead and do it. Okay, so 30 feet with the liver, a mile with the kidneys and the intestines. Heart is pumping and pulled with every breath. The heart's in there like boom, 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 boom. But it's not, but it's getting this with every breath because it's pulled down. The heart is connected to the diaphragm. Okay, it's connected to the diaphragm. Okay, the entire vascular system is stretched and up and down, it's moved, and that maintains its elasticity. If the vascular system has a trauma on it, and remember that if a nerve is irritated, the body will guard that. And so if there's an irritation on the vascular system, it will stop being as elastic. It will create a guarding. It will start locking it down. And so now you have a hard pipe instead of a nice elastic pipe that's going to be doing this, right? And so if that happens, the vascular system will literally block the diaphragm's ability to move. So if things are not moving and elastic, the diaphragm can't do this. And if you can't do that, then you're falling into the breathing pattern disorder category, which most Americans are in. And so this is why this is the most important talk that you've probably heard as a healthcare practitioner. You have to understand how this works, and you have to understand how to rehab it. Okay, so the pelvic floor is active and flushed of septic lymph. What does that mean? So let's go back up here. Okay, so as the diaphragm drops, all of this drops, and hopefully if you get full excursion of your diaphragm, eventually everything will push into your pelvic floor. And so your pelvic floor is a diaphragm. It's the pelvic diaphragm. Pelvic floor, pelvic diaphragm, same thing. Okay. And as that push goes down, and say you take a uterus that's sitting in there, and how does a uterus move its septic waste out? Well, through movement. And so movement from above the diaphragm comes down, pushes the uterus. Now, as breathing happens, you've got to stack, right? This diaphragm, your respiratory diaphragm is moving like this, but at the same time, the pelvic floor will match and they'll do this. But when you stabilize, they'll snap shut. And so during the stabilization phase, what happens? Oops, sorry about that. What happens during the stabilization phase is you've got your respiratory diaphragm here moving down and your pelvic floor, pelvic diaphragm moving up. And what that does is keeps you from urinating and you don't have a blowout. And so women who are mostly the postpartum women who are having trouble with leakage there, their diaphragms are no longer coordinated because they've got a breathing pattern disorder and it's probably related to that pregnancy, right? And it's not just they're weak. And doing Kegels to fix that problem is absolutely crazy because what that does, it only works one set of muscles. It works the levator ani, and that muscle is going to be too tight. So if you over exercise a single muscle outside of a system, you're going to create a dysfunction. And so we're finding that women who've over Kegeled, they do too many Kegels, they're trying to tighten up their pelvic floor and stop this leakage. They've actually created a dysfunctional pelvic floor because a tight muscle, a constantly contracted muscle, is no longer functional because it's too tight. It's already contracted. It can't contract anymore. And the diaphragm of the pelvis is a bowl, and it's a collection of muscles, and they need to coordinate together. And that coordination has to happen. It has to be in tune with this respiratory diaphragm up here, because when this goes down, this needs to be the pelvis needs to be in a relaxation phase. If you're just sitting there breathing, it's relaxing, it's just going down with it. It's all good. But if you're stabilizing and this is coming down hard from the top and you're creating a lot of pressure, that pelvic floor needs to come up, and so you don't have a blowout of urine, right? And so coordinating the diaphragms and getting real pelvic function is way more important than one muscle, the levator ani. Okay, so Kegels are crazy. They were invented by a man. That guy did not have a female pelvic floor. The female pelvic floor is more complicated than the man's. Man's is pretty simple, straightforward. Okay, let's go. So that's what that means. There's your organ movement. So screenshot that. That's where you can tell your patients what it is. We're making a poster that'll have this information. Okay, so I'm not going to go too much into this here because I've got the stability lecture coming, and I hope you're going to watch that because we're going to break down how stability works and crush some common thoughts on basically muscles holding you up and muscles supporting your low back. It's nothing even close to that happening. It's this stabilization pattern that's holding you up. And so the inhalation phase. So the inhalation phase, pushes like a piston. So the diaphragm here is like a piston. It's a piston. And your abdominal wall is the cavity of the piston where the pressure is created. And so inhalation coming down here creates pressure here, and the particles within your guts gets harder and there's more pressure going out. So it's basically increased pressure, like a soda can that's full. And then if you open the top and you squeeze that can, you're going to shoot the soda can just shoot right out because the pressure is released. And so, but there is no pressure release on this system. And so the harder you bring this down, the more pressure created in this cavity, the stronger the force is on your spine. And so as it comes up here, the pressure is decreased and there's less pressure on your spine. Now, the amount of stability you get is based on how hard this piston can come down and how strong the muscle system, the flat muscles, the transverse abdominis, the internal and the external oblique, how strong they are in holding that. Now, if you've got diastasis, thinning of the abdominal wall postpartum, or some men have diastasis, we rehab that all the time, actually. It's not a big deal. When the abdominal wall is thin, then there's a little bit of a different way to stabilize that. But it's the abdominal wall that's going to hold that, right? So the piston comes down, that's the diaphragm, and the abdominal wall, it's mainly the flat muscles. You're looking at transverse abdominis, internal, external oblique. They're going to be the catcher of that. So it's eccentrically loaded, and at some point, those muscles are going to catch the pressure and maintain that pressure. And so we're going to talk about that in a little more detail in the stability lecture. Okay, let's get going. Okay, so we're going to go through exercises and coaching the breathing back in and how to like get the diaphragm to go straight without manual therapy using exercises. This lady is doing it all wrong, but we'll talk about that in the exercise. This is pretty good, right? You see his alignment here? This guy's alignment is straight. So there's actually an oral fascial diaphragm that tracks it. This is tracking as well. So there's the three diaphragms, and actually you could think of the dural membrane on top of your head inside as another diaphragm. I actually do think of it like that. This guy's got good alignment here. So his pelvic floor, pelvic diaphragm is aligned with his respiratory diaphragm, is aligned with his oral fascial diaphragm, and he's ready to do a lift. It looks really good. This woman is even better than he is. And in alignment. This woman is not good, but she's in the same position. See, if you take this squat position and you just invert it, that's the same position. That's why we exercise in this position, because it's unloaded, right? But her hips are internally rotated. She's falling in, and she does not have that oral fascial alignment. So she's not stable. You will not see babies during development. That would be a moving phase for a baby, but she's just hanging out for a picture. So that's an example of actually how not to do the exercise. Let's go. And we're going to talk about that more. We're going to break down some common misconceptions about stability with proof that is pretty hard to argue against. Okay, breathing pattern disorder is an overuse of the muscle system, because if you have a breathing pattern disorder, you're not using your diaphragm in its normal way to breathe, but you're also not dying. And so you have to get your air somehow. And so you're using what's known as the accessory breathing muscles to get the air in. So instead of the diaphragm going up and down, you're actually lifting your rib cage up via the accessory breathing muscles. And I'm going to go into detail on that during this talk. Now, simply releasing the muscles of your neck and your chest will not relieve the pain caused by a breathing pattern disorder. It will not relieve the pain caused by a breathing pattern disorder. And the reason why is you're breathing 20,000 times a day. If you're hyperventilating, if you're in a breathing pattern disorder system, you're not breathing 20,000. You could be breathing up to 40,000 because your breath is more shallow. You're not getting deep breaths. You're getting a bunch of little shallow breaths. And so those shallow breaths are coming from your scalene muscles here, your pec minor, and etc. I'm going to talk about that pretty soon. So the source of the pain needs to be addressed. You just can't rub these muscles out and expect a real result, right? You can loosen the muscles, and then your client leaves and they're back for the exact same problem over and over and over again. They have these trigger points and they're continuously just returning. The reason why they're returning is because you haven't rehabbed the actual problem, which is the way the diaphragm is able to function. You have to rehab the breathing pattern disorder. So there's an exercise component that's unavoidable to get these people online. Okay, so here's some flow charts that we made. And basically I took the Scheitau book, broke it up into 4 different flow charts in a way that just takes that book and makes it make sense. Okay, and so what happens is breathing pattern disorders, your upper chest breathing, you're using your pecs and your scalenes to breathe. And so they're overactive because they're continually being used. So the SCM, the scalenes, and the pec minor are overused. You got chronic neck tension from your 20,000 breaths plus a day because you're lifting and you're hanging your shoulders off of your neck, right? And so that's your chronic tension. You get a cervicogenic headache, you have neck pain, and you have thoracic outlet syndrome, which is medial nerve pain or numbness tingling down where the nerve gets entrapped, but it's entrapped in the shoulder. It's entrapped in the thoracic inlet right here, okay? And you get loss of lower rib mobility because you're not expanding lower ribs. So you're not expanding lower ribs here. You're pulling upper ribs up and down. There's really no rib expansion. It's all straight up and down. And you think about it, if I lift my rib cage and hang it off of my neck 20 to 40,000 times a day, will my neck hurt at the end of the day? Probably gonna hurt. Okay. And then what that does is because your ribs are locked down, you're going to perpetuate your upper chest breathing. So the upper chest breathing just continues. Okay, and so the next flow chart. Okay, oops. Okay, here's the anxiety cascade. And so, can breathing pattern disorder cause anxiety? Absolutely. So, you have your triggering event, your trauma, or you're into your breathing pattern disorder. And so, that breathing pattern disorder is a fight or flight breathing pattern. You're using your accessory muscles, you're using these muscles up here to breathe. Your brain uses those muscles to breathe when you're being chased by a tiger, when things are going wrong and you need extra air. And so your body thinks there's a tiger. You're in sympathetic dominance, you're in fight or flight. You're in a low grade fight or flight all day. Okay, if you're breathing like this. And so you get neck shoulder pain from overuse of the accessory breathing muscles. The pain bugs you, and that creates anxiety just because you're in pain all the time. And then your fight or flight creates a higher pulse rate, higher blood pressure, rapid breathing, stress hormones are released from the adrenal glands, your digestion slows down, you can't poop because you're not digesting if you're in fight or flight. Your body is not worried about digesting your lunch if you're being chased by a tiger. Your body's not worried about fighting a virus if you're being chased by a tiger. It is worried about shutting everything down, shunting blood to your extremities and running. Right? That's what's going on. And these symptoms are disturbing to the patient, which creates more anxiety. And the anxiety leads to more upper chest breathing and more hyperventilated. Okay. All right. So here's the chemical cascade from a breathing pattern disorder, right? So your upper chest breathing. Now you're having shallow, inefficient oxygen CO2 exchange because the transit time, you're not getting the air deep down into the alveoli, right? It's just shallow. And so the transit time, the speed of it, it's a simple just math, right? The speed of it is less. And so your body just can't absorb. It can't get the CO2 off of the hemoglobin and get O2 on, right? And so what happens is you get carbon dioxide buildup in the blood. Now, carbon dioxide, as it builds up in the blood's going to become too alkaline, right? It's going to start becoming alkaline. And so as that alkalinity grows in your blood, the body's going to start dumping its calcium. Okay, it's just going to start dumping calcium because calcium's alkaline. It's going to maintain that pH like 7.3 is really where you want to be. And so you can only go up or down a point or you'll die. So 7.3 is about where you want to be. And so your body's like, well, I better get rid of my calcium so I can keep my blood pH perfect. And so without the calcium, nerves and muscles function poorly. And so you're going to start getting cramps. You're going to start getting like a restless leg syndromes, just muscle pain. Your tolerance for pain is going to be less, and just basic muscle tensions. And so what does these symptoms cause? Stress, anxiety, body pain, and it's going to put you in fight or flight. It's going to give you anxiety. And now you're on the anxiety chart and you're back into upper chest breathing and around these charts you go. Okay, so breathing pattern disorder is not a disease, it's a disorder, right? So you're not diagnosing anybody with anything. You're going, this is the way you're breathing. That's wrong. Let's fix it. Okay, and it's simple to fix. Okay, but you can get a breathing pattern disorder that's going to coexist with a disease. Say you have like heart disease or a lung disease or a liver disease, anything that's going to create lack of movement of the organ above and below the diaphragm will contribute to a breathing pattern disorder. So will bad posture. So will desk work. And so will looking at your phone all day. And so find a kid without a breathing pattern disorder, right? You're going to see that child plays outside all day, right? We pull in, we assess every one of our patients with this breathing pattern disorder. And the only people that are not positive on that test, they don't have it, are people who work outside. They're like the ranchers in northern New Mexico. These guys are fully stable. They're breathing. They're coming in because, a bull stepped on their ankle or something. But they don't have breathing pattern disorders. They're rock solid. It's your desk workers, your PhD scientists. These guys are they have breathing pattern disorders. Moms, postpartum, because the baby, they need some rehab on their breath and the movement of the organs, because the baby smashes your organs. And you think 9 months, slowly pushing your organs in place, and that baby's pretty big by the end of it, and it's just smashing your spleen up, and it just gets stuck to your rib. Now your spleen's not moving. If your spleen's not moving, your diaphragm can't move on top of it, and now you fall into a breathing pattern disorder, and now you're on the flow charts. You're on those flow charts. Okay, breathing pattern disorders can modify your biochemistry. Okay, we talked about that some, but also your digestion. As your digestion fails, your absorption of nutrients fail. Say you need your minerals, your salts to make hydrochloric acid for your stomach to function. Well, if you're not absorbing those minerals, well, you're not going to make hydrochloric acid. If you don't make hydrochloric acid, well, now your first level of digestion is broken. Now you're not going to digest food, right? And so there's a pretty significant cascade. And then the lymphatic septic buildup, especially in the pelvic floor and the female pelvic floor, because it's farthest away from the respiratory diaphragm. It's the last thing to get the squeeze. And so as the diaphragm loses its depth of excursion, it can't go down as far. The first thing that goes septic is the pelvic floor. And so for women, it's incredibly important to get that pressure on that uterus, because they're going through menses. And could you just imagine not getting full waste products out of you, every day? There's a problem there, right? And so this is why this is so important to rehab on people. It's the most important thing you can do. Okay, so musculoskeletal structures go into dysfunction, and I'm going to talk about that because breathing pattern is directly related to posture and vice versa. I'm not going to talk too much about like pathology stuff that like your ears, nose, and throat guy can do. I'm hoping that you're working with these guys, and if somebody has an occluded nose and they just can't breathe, that sometimes you just have to go get surgery, right? And that fixes it, and it's awesome, right? It's awesome. What you need to do is rehab them post-op. Do a post-op rehab, make sure their cranium's all good to go. But make sure you're working with a team of practitioners. And if somebody's actually can't get through and the hole's too small, that you recommend them to get surgery and then come back to you. And you can rehab their breathing from there. Okay, a breathing pattern has been shown to be capable of producing symptoms that mimic real diseases. Now, this is real, okay? You can think you have asthma, but you don't. You can have colon spasms. You can have irritable bowel syndrome, but it's actually the diaphragm's function and not working. You can think you have heart problems and think you have angina, but you don't have angina. You've got a breathing pattern disorder. You can have alkalosis. You could have acid reflux due to posture and diaphragm function. This is an important one. Let me talk about this one. Now, here's something that I didn't know for a long time. So this hole here, so the esophagus goes through that hole. Okay, and so the esophagus, so you've got the esophagus coming down like this, and then you got the diaphragm, so about a half inch, so like a half inch underneath. Then you've got the lower esophageal sphincter hitting the stomach. And so the diaphragm is actually part of the closure mechanism of the sphincter above the stomach. And this is an important piece of physiology because that's a weak sphincter. So the sphincter at the base of the stomach, this cardiac sphincter here, is stronger. So this sphincter, where it dumps into the duodenum into small intestine, is stronger than this sphincter, and that makes it so you can vomit, right? And that allows for vomiting to happen. But what happens is with acid reflux, which I'll talk about in detail in the digestion talk, you're losing the diaphragm function on the sphincter. Okay, and so that's coming more in the stability talk. We talk about the how babies develop, and so you can see why babies, they're spitting up on you, and then about 6 months they finally stop just spitting up so much, and the reason why is their diaphragm is now coming online. at 6 months. But that's also where their stability is really coming online too at the same time. So the diaphragm holds you up, keeps you from spitting up. And if you're losing that function, you could very well be going into an acid reflux situation. And acid reflux is related to posture as well. Okay, keep going. Okay, this is Loom's perspective. This is 1975. So I'm putting this on here because this guy wrote this in 1975, and that's like 49 years ago. So what's happened here? So he said breathing pattern disorders affect your emotions. Okay, so your self-confidence evaporates and secondary problems emerge because you have this disorder. It's maybe not diagnosed. You've gone to every doctor and they call you a malinger. They think you're a hypochondriac. Nobody knows what's wrong with you. You have these symptoms, but there's nothing wrong, right? There's nothing wrong with you, okay? And so they create avoidance behaviors and phobias, and they have extreme anxiety, which we understand now is also a chemical cascade, okay? When in fact, this breathing pattern is the major cause of stress and anxiety, which we saw in the flow chart. Okay, they suffer without social support given to more tangible life events. So if like say you had a heart problem that was diagnosable, you're going to get the proper care, the proper attention. Your family's going to understand it. If you just have a breathing pattern disorder, you're probably undiagnosed. You're not getting care. It's being ignored, and people just think they're crazy, right? And so explaining this to your patients is extremely important, and it's extremely empowering. It's empowering to you as a practitioner because they're going to be like, holy crap, why didn't anybody tell me this? Yes, this is what's going on, because they can just look in the mirror and watch themselves breathe. If you sit in the mirror and you breathe and you see these muscles flex and your clavicle raising, well, you've got a breathing pattern disorder. And so we give them the flow charts, we show them this. I'm going to put all this on a poster, and in the class, I'll make those posters available if you want to use that to explain to your clients. Okay. And so he says, Loom in 1975, it's time to make breathing pattern disorders acceptable by medical professionals, a disorder that people can freely talk about and find effective help and treatment. And so now it's 2024 and we're still here, right? And so this is one of the important reasons why I'm doing this class, because it's about time. We need to change this. Okay, so what causes your breathing to go upside down on you like this, right? You can have a physical injury that would just give you, say you broke your nose and you became a mouth breather. Mouth breathing will cause a breathing pattern disorder for sure, which we'll cover. You could have a loss of a loved one. I mean, that'll flip you like nobody's business. Okay, so there's a typo here. So if you have a history of abuse, chronic sinusitis, right? That's where you got to get them to the doctor. So it could be a profound thing that started it, or it could be trivial. It could be trivial, right? You could have sat and studied too much for, if you're a lawyer and you're trying to take your bar and you sat in this position for months, studying, and now you got a breathing pattern disorder, right? Because of the postural thing. But if the patient understands why the symptoms occurred, they are more likely to commit to change. They'll get behind your treatment and they'll get better quicker. Okay, so what can we do as a manual therapist? What can we do with exercise and just manual therapy? What we can do is, unless it's pathology like heart disease, we can completely turn this around. Okay? All musculoskeletal structures are dependent on respiration. Okay? The breathing pattern causes alterations to your posture and your organ function. It causes upper cross syndrome. We're going to talk about that. Your shoulders and upper chest tensions compress the thoracic, pushes the expansion towards your neck. There's a typo there, sorry. Tense upper abdominal muscles limit diaphragm movement. So we can fix this. We can loosen the abdominals. We can get the diaphragm moving. We can get the organs out of the way. We can rehab their upper cross syndrome. And then structures of the MSK system can force overuse of the accessory breathing muscles and maintain the person in breathing pattern disorder chronically. We can 100% rehab the breathing pattern disorder, stop the overuse of the neck and the pec muscles, stop the overuse of this stuff here in their neck and get rid of that neck pain, relax their neck, and totally turn around breathing pattern disorders. We can do it all. As a manual therapist and an exercise specialist, this is in our box. This is where we're going to shine. Okay, so this is the thoracic outlet syndrome I said I was going to talk about. Okay, so we've got thoracic outlet syndrome here. It's often related to a breathing pattern disorder, and this is why. So you got middle scalene here, you got anterior scalene here, and what that does is it takes the brachial plexus, which is the nerves that go into your arm, and pinches it off. So if your middle scalene and your anterior scalene are short, they're going to squeeze and it's going to literally pinch off. It's going to pinch the brachial plexus right here, right? If the thoracic inlet is overworked and it's got a guard and the first rib is going to come up, because your first rib is connected to the scalene, that's going to bring that rib up. And so you got your clavicle here and your first rib underneath like that, those two are going to shrink like this. And what's going to happen is as they compress, it's going to approximate onto the brachial plexus. That's going to cause the brachial plexus to get pinched there. And then the brachial plexus runs underneath. It runs underneath here. It runs underneath the pec minor. And so what are your accessory breathing muscles? Your pec minor and your scalenes here, the SCM's involved. And then so you're going to have compression in 3 different possible locations, right? And so it's going to compress in 3 possible different locations. You're going to have this one at the first rib, the clavicle, and then at the pec. And so if you pinch the brachial plexus there, they are going to have numbness tingling into their hands somewhere, right? And so oftentimes they think they have carpal tunnel syndrome, but it's not. It's hardly ever carpal tunnel syndrome. Honestly, it's thoracic outlet syndrome almost every time. And so this is why, because these are the accessory breathing muscles. When your diaphragm here cannot go down, these guys take this system up. You've got to get rib expansion somehow, right? If your diaphragm's not going to go down, it's going to take it up. You've got to make this cavity has got to be larger to suck the air in. And this is how your body does it. And so the more you do that, the less you're going to be able to move the diaphragm, because organs, if it's not moving, they're going to stick together. And so your body is a system moving in space and time, right? And so you take an organ and you stop moving it, it's going to get sticky. It's going to stop. The diaphragm can't move through that. And now you're going to use these muscles instead, and you're going to end up with numbness tingling in your hands. And to rehab that, you need a good thoracic outlet treatment. If you don't have a good thoracic outlet treatment, you need to be emailing me and let me give you one, right? Let's figure it out. We've got a great one. But there's no way you're going to rehab this without knowing the exercises to rehab the breathing. It's not going to work. Okay, so rehab the breathing is number 1 in treating thoracic outlet syndrome. Okay, so this is Collins in 2012. Okay, so what he's saying here, I'll just read it, because if you're on your phone, then you're not going to be able to see this. Okay, so when breathing is withheld or highly costal, meaning going straight up accessory muscles, respiratory muscles are constantly being overactivated. The head is pulled forward and the shoulders are hunched up and pulled forward. And a common observation is increased sway in the low back. Okay, now they're getting what we're calling cross syndromes. The pelvis is tilted forward simultaneously as the back is overextended, resulting in misalignment of the entire body. So this is where the breathing, the respiratory function is now deforming the body's posture from an aligned posture to a pretty crooked posture. Okay, this may cause pain in adjacent muscles of the back and pelvis, and I'm going to add the neck. The possibility for free and deep breathing is inhibited in this position. And so they lost the breathing and they drop into this position, which is inhibiting breathing. And this is why it's a dangerous cascade that actually needs a little interference from a professional to get it rehabbed. And this is that position. So this is Yanda's upper and lower cross syndrome. We all know this person. This is like 90% of your clients. This person's in pain. Okay. Where is this person's pain at? Right there. TL junction, the lumbar sacral junction, and then at the cranium to the cervical junction. That's where they hurt, right? We all know that. But you're not going to rehab this person without taking the breathing seriously. Okay? And so what happens? You should probably screenshot this and so you have it. Okay. So what's going on here? So the pecs are getting tight, the upper traps are tight, the levator scap's tight, and the SCM tight. And so if a muscle is tight, okay, it's a weak muscle because it can't function. It's like already contracted. So the whole system is weak, right? And so these muscles are weak and long. The lower trap, middle trap, serratus anterior, and the rhomboids. And so one of the exercises that we do is activate serratus. You've got to get serratus activated. You get serratus activated, the shoulders start coming in alignment, right? And so this is extremely important. The head will always align over the pelvis. Always. The head and the pelvis will always align. Sorry, my line's a little crooked. And so the sacrum will always try to slip under the cranium. And this is so your center of gravity is correct and you don't fall down. So if you have forward head posture, eventually your butt is going to start tucking under your head, okay? And then so you're going to end up with what's called lower cross syndrome. This is all from Yanda. This guy was a genius, this guy. He was from the Eastern Bloc. He was like a Czechoslovakian, and he actually started a lot of this thinking about tensegrity, right? And I think he doesn't get enough credit for how far he pushed us, the manual therapy and the exercise specialist, right? So Yanda's lower cross syndrome. So screenshot this sucker so you have it. Okay, so all are tight and short. They're all weak. Okay, they're all weak, under functioning. Now, not physically weak, but neurologically. If it's contracted, it can't contract anymore. And if it's long, if it's stretched to its max, it can't contract. So this person's got a real problem. Okay, so hip flexors, the TFL adductors, and the erector spinae are all tight and short. We're talking about the bottom half of him now. Okay, the abdominals, the glutes are long and weak. Stresses commonly appear in the sagittal plane. The QLs are tight. The glute max, glute medius. This is like people say, oh, your glutes are off. Your glutes aren't working. Well, if you get the breathing on and you get them aligned, their glutes will start coming online, right? And the glutes will start coming on. So instead of looking at like rehabbing these muscles as individuals, start looking at the system. Like look at the global pattern of what's going on and think about the body globally, and don't just go, well, let's get to do some glute exercises and get your glutes on, right? Because that's actually only a small piece of the entire puzzle, right? You want to neurologically rehab this person. You want to get their breathing on, get the diaphragm function going, get them stable in their core. And then once now the body has something to actually hold on to, then you can bring in stability of the extremities from there. And it'll just start happening because it happened before. Because most people, through their developmental sequences as a baby, they were perfect before they ran into these patterns. So your body knows what perfect stability for the individual is. And so we're just bringing that back. So I'm not going to read all this, but you can screenshot this. This is the results of upper cross syndrome. I think I pretty much talked about this. One of the things I want to add this. And so if you have this posture here, if this is long here, your erector spinae, it's going to pull on the back of your head a lot more. And it's going to hit the myodural bridge. And so if you're unfamiliar with the myodural bridge, you should look that up. It's where your suboccipitals are directly connected to the dura, which is the membrane around your brain, directly connected. So if you pull your suboccipitals here, eventually the dura will come back, right? And so there is your cervical genic headache. Genic, like Genesis in the Bible, the beginning, cervical, so it's your neck headache. It starts in the neck. Okay. And then we're going to get some stress down to the fourth vertebrae. Always, that's your mid back pain. It's like, it hurts between my shoulders. You're going to have the scapula is going to be out. You got to get the serratus on to fix the scapula position. It's going to bring your shoulders back. Okay. The altered shoulder angle is going to throw the humerus off, right? And if any joint is not centered, you will get arthritis and bone spurs in that joint over time from the asymmetry of the muscles pulling on it. Okay. Breathing function is going to be negatively influenced because you're slumped forward. If you're slumped forward, your diaphragm doesn't work. If your diaphragm doesn't work, you're slumped forward. That's why it's you need to have somebody stepping in to help. So here's what happens with lower cross syndrome. Okay, you're going to have more strain on the TL junction, right? This is at the T11 to L1 sections, right? There's going to be pain there. And if there's not pain there, what they're going to feel, let me give you a pro tip here. So you've got T11, 12, L1, 2, 3, 4, 5. Now, the sympathetic trunk here. So if you have pain here, count up 1, 2, 3, 4, 5, treat there, treat that spot. And if you treat that spot, this pain will radiate there. And so count up 5 for the low back, just count up 5 and treat that spinal unit, and you'll find that pain will go away. Okay, that's how the nervous system works. There's a whole pattern for that, but that's like a pretty good rule of thumb. So if it's low back, fix your thoracic cavity. Go and fix the TL junction, especially. Okay, but what happens if you're chronically in this lower cross syndrome? Well, there's a thing that happens over time as you degenerate. It's called spondylolisthesis. Spondy meaning back. Okay, usually at L5. It's a Greek term meaning a vertebrae sliding down a slippery path. And you have poor pelvic control. And the poor pelvic control comes from the lack of the respiratory function above. So this is spondylolisthesis. Now, what happens with the spondy, and we'll call them spondies for short, but they're spondylosis, and that's just degeneration of the spine. This is spondylolisthesis, where you have the pars. You have this section right here, and what happens is from this chronic pull forward, just chronically pushing, so you've got this going on chronically, eventually it just breaks off. And then so if it breaks, now L5 is slipping on the sacrum. So we'll see this L4 slipping on 5 or 5 slipping on the sacrum, right? This can happen from a breathing pattern disorder. You go into lower cross syndrome, you age 30, 40 years, and now you got this thing that your spine just breaks. And there's a lot of fascia, there's a lot of ligaments to maintain that. And so usually the slip is like less than a 25% slip, but it still pinches this nerve. Now we've got a great treatment for this. We don't need a spinal fusion for this, right? What we're not going to do is we're not going to fix that vertebrae. What we're going to do is we're going to give them stability and get the pressure system of your abdominal to push this back over and maintain that. Okay. With manual therapy, we'll just grab this thing and pull it back. We'll just literally just grab it and pull it back. And then you need to get the breathing pattern on to keep the pressure on it so it can hold it in place. So you have to rehab the reason why it broke in the first place, right? And it may have been something that occurred 40 years ago. They had a loss of a loved one. They went into a breathing pattern disorder, or they're a desk worker and they go into a breathing pattern disorder. 40 years later, their spine finally here at the pars finally just breaks, right? And then they're like, well, you need a spinal fusion to fix this. But I have never sent anybody with a spondylolisthesis to surgery, ever. We rehab them with the process that we're going to teach, right? These people don't want to get it because it's a rod in your back, right? And then even if you get the fusion, you still haven't fixed the reason why you lost it in the first place, right? So you have to think this way. You have to think like, okay, why'd you lose it in the first place? So we're going to look at posture, breathing relationships, and then end it on this first section. So this is children who are mouth breathers, right? And they're going to be mouth breathing, which is an unnatural way to breathe. So they have some airway occlusion problem. Maybe they broke their nose, or they actually have like something structural here, and they may need surgery to repair that. Now, if you're naturally a mouth breather, right? So if you pinch your nose and you breathe, you're going to be breathing through primary the mouth airway. And so to open up the mouth airway, what's going to happen is you're going to have to look up just a little bit. Now just try this. Try to mouth breathe and then look down and then look up and see how much more it opens the airway by looking up. But I'm looking up and I'm looking at the sky over there. But what I need to do to actually look at the person in front of me is I need to lean my head forward so my eyes are righted to the horizon, right? They're righted to the person in front of me. But if I do that, this is the head position that I go into. Now, if I put the weight of my head in front of me, I'm going to have the anterior shoulder position is going to fall in. I'm going to have the reduced cervical spine curve. My scapula is going to go out of place. I'm going to end up in an upper cross syndrome position. Now, if my head is forward, what's going to naturally occur is my sacrum is going to come underneath my head, so my center of gravity is straight, so I don't fall down. And so upper cross syndrome always leads to a lower cross syndrome, okay? And so these children need to get rehab from the mouth breathing, need to fix whatever problem there is causing the mouth breathing, and then they need a rehab because their organs are not going to move, right? Their diaphragm function is the excursion of the diaphragm. It's not enough up and down motion, so everything above and below the diaphragm is not getting pushed around all day long. And so if we're moving in space and time, and once you stop moving, it seals up. And so this organ will seal next to this organ, will seal next to this organ. It'll start adhesing together, and these children are going to be stuck, and they're going to need manual therapy and exercise for a real rehab, because maybe they've never moved, maybe their liver has never moved, right? But they can be rehabbed, but we got to fix the reason why they're mouth breathers in the first place, okay? And so in this case, the breathing has modified their posture. Now, in this case, the posture has modified the breathing, right? Now, this guy's on a time trial bike. He's in the worst position in the world. His respiratory function is going to be under functioning. He's going to give himself a breathing pattern disorder. All of these cyclists have this, and they have a very predictable pelvic floor dysfunction. It's a very predictable pelvic floor dysfunction. It's like if your tires on your truck or your car are towed in, so they're like this, and you're driving forward with your tires at this angle, right? Your alignment's off. Well, you can say, well, on the outside of this tire here, I'm gonna wear it down. It's gonna just rub my tires away like an eraser. Eventually, I'm gonna have less and less tire on that outside section, and then I'm gonna have a flat. It's as easy to predict that as it is this guy's pelvic dysfunction, right? It's very predictable. He doesn't have the diaphragm alignment. He doesn't have the diaphragm alignment here with the pelvic floor alignment there. It's just not aligned. He's not getting pressure there. And if you're a serious cyclist, you're spending hours and hours a day aligned. Look at his orophacial diaphragm alignment. He's totally misaligned on that bike. But this is his sport. It's what he's doing. And so he's going to need some serious rehab. Okay, so this is where the posture has affected the breathing, and then you can see the posture and the breathing are codependent, okay? And you have to rehab them at the same time and think about it at the same time. Okay, so is there an ideal posture? Okay, the body is a self-balancing system in gravity, right? And it's dependent on the shape of the arches of your feet, the hip orientation, the pelvic position, and the head position, right? If the arches of your feet are fallen, your knees will turn in, your hips will be internally rotated. It's going to affect your hips, and your pelvis is going to tip into that, and it's going to translate all the way up. And there are neural reflexes, infant neural reflexes on your foot. And so when your arch does this, your pelvic floor automatically tightens up and prepares for stability because the arch is being active because it hits the floor with some weight. The arch will flex, and that automatically is an infant reflex, activates the pelvic floor. And somebody whose arches are fallen, very likely their pelvic floor is dysfunctional. And it's very important for pelvic floor stability to have the foot working. They have to work, right? So you've got the respiratory diaphragm, the pelvic diaphragm, and the foot actually they're all involved, right? And I hope during the class we'll have time to go over these infant reflexes. You can take advantage of these and create stability in people. So the human being is a moving, changing system. It's a moving thing, so the posture is moving. And so there is no optimal position. It's whatever position you're in at the moment, right? Is that functioning or not functioning? Okay, optimal serves whatever the human body mechanics needs. Okay, so this woman is very flexible. We can imagine what her posture looks like when she stops. She's probably pretty straight, but she's a dancer, so her hips are going to be externally rotated. She's going to have tight rectus abdominis because that's the way they train in America. And we can imagine that, but that's the optimal posture for a ballet dancer. All right. She's a ballet dancer. And so when she's done with ballet, that's when we step in and we'll rehab her and we'll get all that normalized. We'll just take the ballet out of her because you don't want to go on forever shaped like a ballet dancer because there's a lot of dysfunctional in that, but it creates the dance. And so you have to accept this person for who they are and what they're doing. And when they're done dancing, then we rehab that. It's the same thing with moms. If they're carrying a baby on one side all the time and they don't have a lot of time for the exercises, well, maybe when that kid's 4 and their youngest child's 4, then we could actually rehab the entire system of the mother, right? So you meet the patient where they're at and what they're doing, okay? And so let me see. Yeah, so codependency of breathing and posture, okay? Altered breathing can affect your posture. Okay, a stressful situation causes hyperventilation, causes upper chest breathing, causes upper cross syndrome, causes lower cross syndrome, right? And correcting the breathing and posture at the same time is required. And so when you do the manual therapy, they'll start actually just helping each other out. But you think about it both ways. Okay, if you're just fixing somebody's neck, trying to get their head over their shoulder and their upper chest breathing, well, that's just going to fall back down again, right? So think about I'm going to start at your diaphragm and get your core stable. And so everything can actually hold itself up. And that's going to be talked about in the stability course that's coming up after this one. So the correction must include manual therapy to open the body to allow for breathing. Now, when we first started, we only were using exercises. We were getting results. The patient were working a lot harder than they work today, right? If I work on a person, I do this sequence, they're breathing when I'm done, period. And then we just start right away coaching in stability, right? And so, but if you don't know the manual therapy, or the manual therapy is not in your scope of practice, well, then you can pick up the breathings. If you can't take our basic class on breathing, the dynamic neuromuscular stability classes, this is out of Prague. I mean, they're excellent. They're excellent, but they take it pretty far. You know, they're great classes, right? I've taken all of those. I'm certified through them. We're just entering the basics of the breathing pattern disorder, okay? They may need some psychological therapeutic help to manage the emotional problem that if that's still going on, right? If the breathing pattern disorder is caused by something that's continuing in their life. And in our clinic, we use the neural reset treatment. You can read about that on our webpage. And the breathing pattern dysfunction MSK cycle, okay? Changes from the breathing pattern disorder run physically against our normal biomechanics. We know that now. Structures are altered, which disallows them to return to normal on their own. The adaptive capacity of the body has been reached and exhausted. We're going to talk about that in core stability. And the structures break down as a result of a cycle of more and more pain and dysfunction. People with breathing pattern disorders need intelligent intervention to reset the system. Okay, and that's us. Okay, but your therapy is another stress factor. Say this person has this disorder because of stress in their lives, and you add more stress from your therapy. And here's a rule that I use in the clinic. It's a quote from Leon Scheitau. The more ill the patient is, the more symptoms that are being displayed, the lighter, gentler, and the more constitutional the intervention needs to be. So if somebody is very fragile, you need to give them one intervention. Maybe I'm going to do a little manual therapy. I'm going to relax you a little bit, and I'm going to give you just the breathing. I'm not going to give you too much. But if they're like a person who is able to handle several, like they're a solid person and say they just got it from desk work, then you can throw the kitchen sink at them. You read the room and you read this person. But if you add too many therapeutic interventions, too much homework to a frail person, you're going to lose that client. You're not going to help them. You're going to lose them. So meet them exactly where they're at, right? You got to read your patients. It's an art, not a science. It's something that you're going to get over. You're going to get this experience over time. And if you can, shadow somebody who's more experienced than you. And so the learning curve's faster. Okay, you're a teacher. You're a healthcare professional. You're a teacher. Your patients didn't take this course. Their patients didn't read this book. Okay, so your job is to educate them, right? And convince them that they have a breathing pattern disorder and they're not just being crazy. And you'll be the first person who listened to them and explained this issue. Right? They're going to really appreciate that. And they're going to comply with the therapy, right? So with your education, be factual, get to the point. Don't use words they don't understand. Don't talk over their head, but meet them where they're at and take some time out of your practice to explain to people. Okay. But don't over educate just to prove how smart you are and how much you know, because then there's a point where you're just talking to yourself, right? And they just deer in the headlights look in their eyes. And so you don't want to over-educate people, right? Just meet them where they're at. When they come back, give them a little more. When they come back, give them a little more, right? Okay. So read the ability of the patient to comprehend and use language they don't. You got to use language they understand, and don't use a bunch of medical terms that they don't know. Because if you drop one word in a sentence that they don't understand, you've lost the entire sentence, right? And it's okay to not use medical terminology. Even in our classes when we're teaching, I don't use a lot of medical terminology because even if you're familiar with it, if you don't use it all the time, your brain has to do an interpretation phase. So like move cranially or move caudally, and then your brain has to go caudally. Okay, what does that mean, right? And then by the time you thought of that, I've finished the sentence and I lost you, right? And so that's why I'm not using a lot of those terms in our live classes, right? I don't use a lot here either because that's not the point, right? And so if you want all those terms, go read Scheitau. He uses them all day long. So that's it for section 1 of breathing pattern disorders. We're moving into stability, which is incredibly important. I think that's going to be a really cool lecture. It's super fun. Once we got the work part out of the way, now we're just going to have some fun with the talks. And then we go into the manual therapy after that. So, all right. That's it. This is where we're going next.